Welcome. We have a great turnout this afternoon. I think over 20 members participating in this. While many of us are scattered across the country and a few in Washington, we're holding this hearing virtually in compliance with the regulations for remote committee proceedings pursuant to House Resolution 8. This authority has allowed us to continue to do our work on behalf of the American people while keeping our staff, families, and broader communities as safe as possible. Before we turn to today's important topic, I want to remind members of a few procedures that help us navigate this virtual hearing. First, consistent with our regulations, the committee will keep microphones muted to limit background noise. Members are responsible for unmuting themselves when they seek recognition or when recognized for their 5 minutes. Second, members and witnesses must have their cameras on throughout our hearing. If you need to step away from the proceeding, please turn off your camera and audio rather than logging out. And one last bit of housekeeping. Mr. Thompson will be authorized to take over as chair in the event that I experience any technical difficulties down here in Texas. Let me then offer a few opening comments, and then I'll call on our ranking member, Mr. Nunes, to do the same. Telehealth is a term that has become so prominent in healthcare during our ongoing pandemic. Today, we are trying to chart a path forward on telehealth. And unlike some of the terms we've become so familiar with over the last year that we're ready to retire, like Let's Zoom or 6 feet apart, and the recurring guidance that we'll probably hear again today, please unmute yourself. Unlike these, telehealth is a concept and a term that is here to stay. Yet we need to fully explore how it stays and at what cost in both dollars and quality of healthcare to preserve patient choice, protect beneficiaries from fraud and exploitation, and avoid exacerbating longstanding health disparities. Far more than just a pandemic buzzword, telehealth has allowed essential healthcare workers to provide primary care, specialty care, patient monitoring, case management, all of these while reducing the spread of COVID-19. This expansion has demonstrated that telemedicine can be integrated into health plans and health established physician-patient relationships, and that can be a way to assess the patient's needs. Predating the pandemic, telehealth's promise has long been available, but the past year has charted a path forward for better quality and more comprehensive use of it. For Medicare, the transformation was made possible thanks to waivers that were granted by CMS to cover 144 telehealth services during the public health emergency. This is flexibility that allowed for a rapid and prolific expansion of services for our 24 million Medicare beneficiaries last year, just from mid-March to mid-October alone. Depending upon how we implement it, telehealth can either make matters worse or make them much better with reference to health inequities. Barriers like transportation or affordable childcare are removed. It's a potential with telehealth to improve the patient experience by expanding language access and providing culturally competent care. It has also allowed family members to facilitate their telehealth appointments and be there to serve as advocates for vulnerable loved ones. But the availability and cost of technology and broadband are crucial to make telehealth a successful care delivery model, particularly for economically disadvantaged individuals, for those with disabilities, for people of color, for people who are just not very tech adept. While audio-only visits can increase access, we also need to avoid a two-tiered system where affluent patients receive video and in-person visits and low-income beneficiaries just get a phone call. In his American Jobs Plan, about which we'll hear more tonight from President Biden, he has outlined an ambitious $100 billion expansion of broadband infrastructure, a provision that appears to have garnered some bipartisan support. With CMS telehealth waivers currently extended through the end of this year, we need a plan in place to assure no abrupt suspension. Though recognizing the great promise of telehealth, the Medicare Payment Advisory Commission, MedPAC as we refer to it, last month noted that our understanding of the impact of telehealth is largely limited to data and experience covering only a very few months. It recommended that Congress initially provide a limited extension to permit a little additional time for gathering evidence about the impact of telehealth on access, quality, and cost. And while pay parity between telemedicine and in-person care has spurred rapid adoption, we also need to evaluate the impact on Medicare spending and ensure a telemedicine appointment is not duplicating an in-person visit. A number of our colleagues have introduced telehealth-related legislation. I particularly salute Mr. Thompson and Mr. Schweikert for their proposals for forming a telehealth caucus and for their longstanding telehealth advocacy. While not a markup today, I hope that this hearing will enable us to move forward on a full committee markup on several bills in this area. To implement the Medicare recommendations, or the MedPAC recommendations rather, I'll be introducing a bill of my own to extend existing telehealth waivers following the conclusion of the health emergency. This will permit MedPAC and HHS to evaluate the impact on healthcare delivery, Medicare spending, utilization, as well as access to quality care in order to provide evidence-based recommendations to Congress regarding likely permanent changes to Medicare. With Medicare representing really the primary subject matter jurisdiction of this Health Subcommittee, we are the stewards of Medicare with a special responsibility to protect both vulnerable beneficiaries and taxpayers from telehealth fraud, schemes which predated the pandemic and are not all that dissimilar from fraud that has impacted traditional healthcare delivery. The Department of Justice has reported that 50 physicians were responsible for $1.2 billion in taxpayer losses after ordering unnecessary back, shoulder, and knee braces. In another scheme, Medicare was fraudulently billed $2.1 billion for cancer genetic test. I believe we can mitigate these scams by requiring an in-person appointment prior to ordering high-cost durable medical equipment or major clinical lab tests. The anti-fraud provisions of my legislation would also authorize CMS to audit outlier physicians ordering DME and lab tests at high rates and recover fraudulent payments, as well as to ensure that CMS tracks who's billing for DME and lab tests by requiring that any clinician who is able to bill Medicare directly use their own national provider identifier, the NPI, when they deliver telehealth services to a beneficiary. I look forward to our hearing today from a strong panel of witnesses from whom we have intentionally sought diverse views for what is, I believe, a bipartisan hearing. We look forward to your expert counsel in offering a blueprint for how to best chart a path forward on telehealth by building a system that promotes equity, expands access, and upholds program integrity to ensure that patients receive virtual care with tangible results. And now I'd like to recognize our ranking member, Mr. Nunes, for his opening statement.